Bueno, a continuación entonces tenemos la conferencia, el rol de la informática en salud para el reporte de casos de COVID-19 y la integración entre laboratorios e instituciones de salud y organismos de salud pública en el estado de Utah. Para eso nos van a hablar Catherine Stace de la Universidad de Utah y Damián Borbolla, que ya es habitué del CAIS y esta es la tercera conferencia en la que participa, ¿no? Así que les doy tenés silenciado el micrófono, Damián. Catherine,
Solo de
Damián.
ayuda, yo solo los...
Vos sos
los contactos.
hinchada. Les pasamos entonces el micrófono, su conferencia, su pantalla. Gracias.
So thank you, everybody. I'm going to talk about the role of informatics to support case reporting of COVID and our experience here in Utah and some of the work we've done in the U.S. in general, integrating lab health organizations and public health entities in order to deal with public health reporting. Now it's not advancing. Interesting. Okay, so again, I'm at the University of Utah, and I'd also like to acknowledge others that I've worked with that are that contributed with all this work, and including some folks with AMIA, and there's a presentation that that is in addition to this that you could watch, and also folks at the University of Utah Health System, Utah Department of Health, and the Salt Lake Valley Health Department, that all of this is a team sport. This is not something that I did on my own. So first, I'll just give some background and then talk about the ecosystem for electronic case reporting, talk about the national infrastructure, the knowledge, and the messaging standards involved, and then talk about electronic case reporting specifically for COVID, what we did locally, and some of the challenges and opportunities. So as we all know, public health never sleeps. There's always emerging and routine infectious public health threats that are evolving over time. And, everything from you think hepatitis, and all of a sudden you've got a new outbreak. After hurricanes, you'll have waterborne diseases and all sorts of things continually involve. And this is a great movie, by the way, which is actually a precursor to what's happening with COVID. And so the problem from a public health perspective is that public health threats evolve. New conditions emerge and old conditions reemerge, and populations at risk change over time as you have populations moving for one reason or another. So threats vary by region and over time, and timely and accurate reporting is required in order to have effective control. One thing that we've noticed over and over again is that during an outbreak, existing communication channels must be leveraged because it is very difficult to implement new communication and IT strategies during an emergency. And this is why I think one of my take-home points is that you need an infrastructure that is generalizable and scalable so that you can address those new and old and all the things that are emerging, so that you can address them in real time. So when folks think of public health reporting, they oftentimes start with thinking about, well, what should the laboratories and the hospitals and the clinics be doing? And they should be reporting ELR, which is electronic lab results. They should be reporting case reports. Oftentimes it's done by phone or fax. And that's how events get detected and reported. And then the health department at the local, regional, tribal, state, and on down the line level, they receive the information and then they investigate. And then collaborating with the hospitals, they might implement control measures, get people vaccinated or prophylaxed, or, food handlers and daycare workers restricted, and on down the line. But in fact, public health reporting starts with the public health entities defining what they want to receive and publishing the criteria for that, and making that available for the hospitals and the laboratories in order to know what they're supposed to do. And then we can start to do case reporting. So what do we mean by the logic of, or what do we mean by the knowledge of what should be reported? Well, it should be computable. It should be, you know, it should be logic that can be implemented in automated systems. And public health needs to define it, and then they need to share that logic with everybody involved. So this addresses a problem from the healthcare perspective, which is that there are many conditions that need to be reported. You know, in the US, over 200 are reportable somewhere between measles and hepatitis and on down the line. And they change over time, and they're different by jurisdictions based on what's relevant. And the logic, and they want to know what logic should they apply in order to identify reportable events. Do they need to know it when it's based on diagnoses or labs or confirmed or suspected? And they need to know what information should be included in the case report. And then they need to know what actions they're supposed to take and what happens after they report it. So let me just clarify what I mean by case reporting. So case reporting is, we're talking about reporting person identifiers and clinical information about a specific case. You know, it's so-and-so, they live here, their age, and contact information, and this is their diagnoses and the medications they've received. In the US, it's legally mandated, and sometimes it occurs when illness is suspected prior to confirmation. For example, you want to receive reports of suspected measles or suspected anthrax. You don't want to wait until something's been confirmed. So sometimes it needs to be reported early, and sometimes it's okay to wait. Depends on how likely it is to cause a problem. And oftentimes it's a manual process, and it's still often a manual process. So when we talk about electronic case reporting, what we mean is the automated identification of reportable events in an electronic health record and their transmission to a state and local public health authorities so that they can review the information and take action. So the value of case reporting, electronic case reporting, is that it should be automatic and complete and accurate and in real time, you know, not batch reporting every week or something. It should decrease the healthcare provider's burden and meet the public health needs. And it should support reporting so that you can actually do things with the information, like case management and contact tracing and linking the lab data and coordinating everything. And finally, the icing on the cake is that the healthcare system should receive information back from public health about what's going on in the community. So let me describe to you the ecosystem for electronic case reporting that we have been working on in the US for years. I was the co-chair for this knowledge repository, the RCKMS, Reportable Condition Knowledge Management System, that is the decision support engine that's supporting all of this. So the ecosystem has multiple parts. Of course, you have the EHR, you know, many EHRs throughout the US. And then we have something called the AIMS platform, which is the American Public Health Laboratory Platform, which is a national resource that is used by all the major laboratories to route all the lab results around the US for clinical care, not just for public health, but for, and this has been used for electronic laboratory reporting for a long time. So we added on that AIMS platform a decision support engine that includes all those if-then rules for all the different reportable conditions. And those were authored. This is a project that's gone on for about 8 years. So all this logic is sitting there. And then there's the electronic reporting and surveillance distribution system here, which includes trigger codes, which are based on the logic here, that are sent over to the EHRs so that they can implement the trigger codes in their decision support engines and say, oh, this is an event that's occurring, you know, a positive COVID result or whatever. And that triggers the creation of an EICR, which is a CDA-based document that includes content that is both an input for the decision support engine, but also if it's reportable, the decision support engine says, yep, it's reportable, then the EICR, which is a document similar to a continuity care document or any kind of a CDA-based document, it's sent over, forwarded to public health. And it's forwarded to the public health agency where care was provided. For example, if the patient is from New York City, but they are visiting in Utah and they are skiing and then they come down with something that's reportable, it would be sent to the Utah Department of Health, and it would also be sent to the New York Department of Health because the infection actually could have occurred in New York. So this I'm not going to go into. It's just an alternative way of sending it. Basically, you can send it through an HIE or Health Information Exchange and other different options. But basically, things go from the EHR to the AIMS platform. And if it's reportable, it gets forwarded. If it's not, then it doesn't get forwarded. So I just want to show you an example of what we mean by reportable conditions. The only reason I'm showing Zika is because it fits on one page and it's kind of useful. The knowledge, typically looks like this: report if this and that and da 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 da. I just want to show that some of the knowledge is actually more of diagnostic criteria, not reporting criteria, and it's not implemented. But there's a lot of low-hanging fruit. There's this little arrow should actually go to the red box. What we did implement is laboratory criteria and diagnostic criteria, which is very straightforward should be very straightforward in an electronic health record. And then what we do is we take the narrative statements, we make them tabular, we make structure and standardize it, we vet the content, then we create the value sets and populate them in VSAC, the National Library of Medicine's Value Set Authority Center, which I assume that you all would have access to. And then we implement it in a decision support engine. And so that Zika logic I showed you would have, Zika, it's sufficient to report if you have a diagnosis, and it's sufficient to report if any of these laboratory criteria are true. And then we have logic for vital records. So that actually looks more like this. And for example, if the patient has a diagnosis of Zika, and this is a value set that we then implement in the Value Set Authority Center, and you can see here there are value sets that are continually being updated, with the different code systems, so that you could actually import these into your own decision support systems if you wanted. And those value sets are what create the trigger code sets. So in the fall of 2019, there were pilot sites that were operational both at Utah and in Texas, and the Utah Department of Health and the Texas Department of Health were operational. So this was all set up and going in 2019 for salmonella and chlamydia and 4 conditions. And then all of a sudden there was COVID. But the point that I want to make is that there was an infrastructure sitting there ready to rock and roll when COVID hit. So by April of 2020, COVID was reportable in all jurisdictions, and there was a need for individual case reporting, but it was very challenging. Health systems were having a lot of trouble, and frankly, often manually or sending spreadsheets to report COVID. So there was a need for tools in order to decrease the burden and also to improve the case-based surveillance. So you could see all these dashboards that are now popping up. So I'm borrowing this slide from a talk that I gave with a group of folks at AMIA, and you can go see the whole talk here. But as you can see, Intermountain and the Intermountain and the Texas Hospital are here, and they were humming along with they put on the COVID logic, and they were reporting a few cases here and there. And then all of a sudden, things picked up. And then Epic started working with health systems and running these cohorts of systems and rapidly getting them on board. And so case reporting started increasing rapidly, and California started being able to receive reports. So in April, there were 7 implementations the dots are health systems, you know, like Intermountain has 20 plus hospitals. So all of these hospitals are one implementation. Anyway, there were 7 implementations and about 130,000 case reports, and you know, California, Utah, and a couple of other sites could receive them. But by October 15th of 2020, so this week, the AIMS platform has received over 2.4 million case reports. 46 organizations with over 5,000, you know, facilities have shared case reports with over 61 public health agencies. And all of the public health agencies in the US, plus 10 local, like New York City and you know, the big cities, LA, are connected to the AIMS platform, and they've authored all of their rules in RCKMS, and they are receiving case reports. This is just, it's just amazing. So here in Utah, someone's chatting. How much time do I have, Damian? Am I out of time?
No, you are
No,
fine.
you're
You have 5
okay.
minutes.
Okay, all right. So in Utah this week, I just wanted to show you where Utah is. We are a very high rate. In fact, our hospitals have reached capacity, the ICU capacity. It's not good this week. Everyone is up sort of at wit's end. Anyway, we are, this data is based on, the majority of this data is from Intermountain and the University Hospital, which are the main places where folks are treated and tested. And this data is coming in real time now. And so and here I can show you, back in here, we were doing things manually, literally sending spreadsheets over to the health department, and someone was manually entering this data into the health system. We implemented ECR around in here, and there is no way we could be doing this manually now. And now everything is in real time. It's faster than the lab reporting, because the lab reporting is batched. You know, every night, which means that someone could be not actually, their data may not be received at the health department until 2 days later, based on the timing of when people work. And so this, you know, electronic case reporting is critical. And I wanted to just share with you how all this actually works. And this is very detailed, so I'm going to just do a sort of a high level, what's most important. I think, and doing this kind of diagramming helped us really understand what we were doing. We have the University of Utah Health System. We have ARUP, which is the laboratory. Here's the AIMS platform. And then this is on the public health side. We have the surveillance system that receives the data automatically. And then we have the local health department, which is where the rubber meets the road. This is where the case reports get investigated, where it really matters. It doesn't matter if the data gets here and someone at the local health department can't see it. So what happens here, the green dot, someone, you know, arrives, the physician orders a lab result, a lab test. It goes to the laboratory, it gets resulted. There's actually decision support here about whether it's reportable. If it's reportable, then it gets sent by electronic lab reporting to the health department and gets received into the system. There really should be a little clock here, though, because this gets batched. It's not as fast as you would think it would be. If it's positive, or any result gets sent back to the health system, and for the physicians to see and whatnot, it gets saved in the system. That lab result gets compared to those trigger codes that I mentioned. And if it is a match, which it would be if it's a COVID result with a positive answer, then the EICR gets created and gets sent to the AIMS platform. They receive it, they determine reportability. This is the RCKMS that I mentioned. If it's reportable, then it gets sent to the Utah Department of Health up here, and it gets processed. And together with the lab data, you know, at some point, those two things get matched up, and they get put in a queue for the local health department to see. And then the local health department can, you know, go and find the cases, and they can update any records that they have. They may have gotten reports from some other place, like someone's employer, or the person may have called in, individually. Anyway, they review the data, they assign the investigator, they gather additional information, and, deal with the cohorting and isolation and school shutdown and all those kinds of things. So anyway, this whole process requires all these parts and pieces, and there are a lot of different people involved that all make it all happen. So from our experience, at the University of Utah, since we started in June, we've had over 200,000 case reports sent. The electronic case reporting is critical for reporting and also for managing the case reports. The good thing about it is it's systematic and it's complete and it's accurate. It's faster than the electronic lab reporting, and it's definitely faster than the manual reporting. And it's a decreased burden for the health system. Before this, the health department was actually going into the EHR and asking the Health Information Management Group, basically the medical records department, had folks at nighttime that were looking up all of the progress notes, creating PDFs of them, putting them in a system that then the local health department was having to go in, download, and attach to the files in the surveillance system. And all of that has been eliminated, because now the case reports include information like the medications and whether someone's hospitalized or not, which previously was not available in the lab reports. So the case reports provide key data for linking the lab results together and for the case management and all the follow-up. We do need to do a formal evaluation. We've done, sort of what you would do in an operational sense, and now things are just humming along. So I'm providing a whole bunch of links to the key resources that if you were wanting to follow up and see the details about all this is where you would need to go. And then this webinar provides some of the information and is what we presented last April. So thank you. And if you have any questions, I'd be happy to answer them.
I'm just looking for them in the system now. I have a question though. When you speak about the EICR being sent to someone's home if he had an accident skiing, for instance, this is a sort of a push model, or is it a pull model? I mean, if I am in Buenos Aires, in a state or a province, I can choose what I will see or what I will be warned about.
So the information about so in the EIC, so when this EICR gets created, it includes information about the hospital that's doing the reporting, and it includes the patient's address. And frankly, if the patient, it's dependent on the information that's in the electronic health record. If the electronic health record says that their address is New York or Idaho or something, then it will get pushed. Just based on the information that's here, it's going to get pushed to the relevant state public health agency.
So relevance is in the APHL platform, in the AIMS.
Relevance
of the relevance.
The relevance
is in the information and decided by the AIMS.
Yes, it's routed. AIMS does all the routing, and the routing is dependent on the jurisdiction information that's included in the case report. So if the case report, there's codes for, every state, and so based on the state-based information, it routes it. So it's pushed.
Okay. ¿Alguien tiene más preguntas?
Hi, Catherine. I would like to ask you, first, thank you for your presentation. It's really interesting for us in order to how public health works in the United States, being a federal country as we are. So I would like to know how long it took to the states, the government, to reach an agreement between all the states and the public health systems in order to create the APHL platform.
So the APHL platform existed because it supports the laboratories. And so that platform has been operational for, I don't know, 10 years. I mean, I've heard about the APHL platform for a long time. And so it supports all the public health laboratories. And then, because every state has public health laboratories and the CDC, and it helped to coordinate all that. And then what we did was we just leveraged that infrastructure that already existed to put the decision support engine there. And so every state already had connections to the platform. So that was what's new about it. And every lab already had connections to it. What's new is that the health systems are connecting to the platform.
Great.
So that the thing that took
longer
is actually coming to consensus about the logic. Like when I talk about
that's what I wanted to know, the logic in order to reach an agreement in this list, in order to be helpful for everyone.
Right. So this is the Council of State and Territorial Epidemiologists is all the state epidemiologists around the country. And one of the links that I gave you, in fact, it's here. Oops.
Somewhere there.
Somewhere at the end.
Yeah. At the end, here, there is a, and it's one of the links that I gave you, there is a content repository for all the logic for all the reportable conditions. And this is something that I led with the team, and we worked on for a long time, marching through every condition and coming to consensus about the core default logic. And all the epidemiologists are coming to agreement about what's feasible. And then the authoring interface allows states to modify something if they want to.
Great, because I think all countries are working with this problem or troubles about find an agreement. So what they need to share.
Small question. I mean, you mentioned the legally mandated diseases that you have to report about. Mm-hmm. Are those laws nationwide or state level? Because we have here also the states or provinces are independent and they can make their own law, and any nation law will not apply unless the state adheres to it. So
exactly, it's exactly the same.
Okay, I thought so.
And that's what's the challenge, and that's why
it sure is.
Building this repository, though, the thing is that reportable diseases, the logic behind what should be reported has evolved over time because of need. You know, if something, for example, if you have Zika, or not, Zika is probably not a good example. Well, Zika is a good example. You know, it was a problem in Florida and Texas, but not in Alaska. And so, but that's okay. I mean, and also some places want more specific, want more reporting because they have resources to deal with it and others don't. So, so all of those things are true, but the thing is the differences, the logic can be the same, the core logic can be the same, and the authoring allows people to add different. So what we did was here.
Okay.
Here, this is the core logic, but we actually have some columns in these things that we've developed that are optional criteria, and people can turn on optional criteria if they want more.
A different set of rules for being warned.
Exactly.
Okay.
One thing that I want to mention, I don't know if you guys see the vital records there. So death certificates are also included in this report. So Argentina now had like a big issue with they were like cross mapping different databases, and they found that they have like I don't know, in one province there was like 3,000 more deaths for COVID, and that was because they crossed with the death certificate. So I think that it's important to show like all the criteria that you have in that table to show that all those data sources are incorporated to this to these reports.
Default logic to the logic, yeah.
Yeah. So,
Bueno,
and to be honest, this actually is not implemented with ECR because the vital records comes from, that's a public health resource already. Like ECR is coming from the hospitals, but yes, we are saying that this logic, this is how we would implement the logic in vital records.
Sorry, I will have to let you know we are in time. And let myself know we are in time because I'm wanting to ask some more questions, but unfortunately we ran out of time. So let me thank you for being here and reassuring everybody that you can be contacted or contact us in the CAIS 2020 and ask questions that we will forward to you, and later we will be republishing this in our YouTube channel with subtitles or captions for Spanish speakers. ¿Ok? Muchas gracias. Y entonces vamos a pasar ahora a un intervalo y después viene la conferencia de Martín Díaz sobre la receta digital interoperable del Ministerio de Salud. Gracias de nuevo, Catherine. Esto lo entendés. Gracias. Thank you. Gracias.
You're welcome.
Gracias, Damián. Y nos vemos enseguida. Muchas gracias.
Gracias.
Nice to meet you, Catherine. Thank you very much. Bye-bye.
Thank you, Catherine. Bye-bye.